We are back. Welcome, welcome, welcome to Birth Maryland, where we are breaking inequality and reimagining transformative healthcare. I am Dr. Suleika Michel, and I am here with
I am Dr. Tiffany Wilson, and we are both board-certified OBGYNs who will be bringing to you today another exciting health topic for our non-obstetric healthcare providers.
Awesome. This episode will be discussing first trimester bleeding for our non-OB providers. You know, there are a lot of questions about that particular presentation, whether it's in the emergency room or the outpatient setting, in the offices, the clinics, and what have you. So, Dr. Wilson, you want to touch base with some of the stats on first trimester bleeding?
So first trimester bleeding probably happens in about 15 to 25 of 100 known pregnancies. If we are considering some of the statistics regarding first trimester bleeding and pregnancy loss may occur in about 50% of those pregnancies, usually secondary to chromosomal abnormalities. But the good news is, and what that means for a lot of our patients is approximately 75 to 85% of those patients will not actually have a pregnancy that ends in a loss, but will have bleeding secondary to a more benign cause or lower risk factor condition. So we are going to help you to sort of pick through and make the correct decisions and diagnoses for your patients based on their presentations.
Absolutely. So we know as OBGYN providers that once these patients get those positive pregnancy tests at home, I know for me, I was super excited with my first pregnancy when I had that first positive test. And so sometimes they just want to get into the office sooner rather than later for confirmation or just to make sure everything is okay. But if they're having any type of bleeding, they definitely want to get in there sooner. What kinds of tests do you normally have patients get when they first present with a bleeding in first trimester?
If they're presenting me with bleeding in the first trimester, I'm gonna be very honest. The first thing that I'm going to do is a pregnancy test.
Agreed.
We got to make sure that the story fits. And
right.
As an OBGYN provider, sometimes people come in and the story makes a whole lot of sense, and then the pregnancy test is negative, and you're like, okay.
Right.
First thing you want to do is confirm that there is indeed a pregnancy that we are working up. And so once we know that, then the next thing you want to do labs wise, or the next thing you actually want to do is maybe hold on any more lab work, but really sit down and talk to your patient and take a good history.
Yeah.
So figure out what's been going on. So you want to know things like their last menstrual period and if they have regular menstrual cycles, so that you can get an idea of maybe how far pregnant they are. Other things you want to know are sort of what was going on around the time that the bleeding began. So is there any recent intercourse? Have they been doing any strenuous activity or heavy lifting or anything like that? Is there any concern for any potential sexually transmitted infection or any trauma to the cervix? And we'll talk a little bit more about what that might mean. And additionally, especially in the changing climate, we really want to talk about any sort of recent surgical procedures in the cervical or vaginal area, especially because with some of the changes, patients may be seeking more unconventional or non-traditional methods for pregnancy interruption or termination. So I would start there as far as history taking, and then I'll let Dr. Michel talk about what we do next and like what labs and things we order to follow up.
Yeah, so definitely take a good history and really listen to what they're telling you. And sometimes you may have to read between the lines with some of the information that they're getting. But after you do that great history, then the exam is usually next. And doing a good pelvic exam is going to be really key to get some information. And the things that we normally look for are potential infections or just irritation of the cervix. Sometimes the bleeding isn't coming from the pregnancy itself. It's coming from the cervix. So looking at the cervix, seeing if it's irritable, if it looks what we call angry and just kind of bleeds easily, just even with the touch of a Q-tip. If there's any unusual discharge there, get that, test that. There can be infections that are pretty benign, not sexually transmitted, such as bacterial vaginosis, BV, yeast infections, those kinds of things can also be treated with medications in pregnancy. So I would get that discharge and test that. If it happens to be a sexually transmitted infection after that testing is confirmed, that can also be treated. If you're not really sure which medications to use, call your OB, call your OB. A lot of times the feedback on the information for sexually transmitted infections is not immediate. Perhaps if you're in an emergency room, they may be able to give you some information more quickly, but if you're in an outpatient setting, a lot of times that information isn't able to be obtained immediately. So sometimes you may have to potentially treat empirically for yeast or bacterial infections or what have you. But if you're not sure, don't hesitate to give us a call. Send them to us, and so that we can kind of pinpoint exactly what's going on. If you're noticing that they're, or that they mention that they're having bleeding after intercourse, we call that postcoital bleeding. And that can also just be an irritation from the cervix, or any type of infection in the vagina as well. But it can also be from something we call implantation bleeding, which is not uncommon. It's a little scary for patients to have bleeding at any point in their pregnancy, but sometimes with implantation bleeding, as the fetus and the placenta are finding their home and their space and implanting in the uterus, sometimes the placenta separates a little bit, and in the process it has some bleeding, and that can be exacerbated with intercourse. So get that information to see if they've been sexually active in the prior 24 to 48 hours to get some more feedback on that. And then if you need to move forward with additional blood work or some blood work, the blood work that we recommend is at least getting an HCG quantitative, not the qualitative. The qualitative just says yes or no that they're pregnant. We need to get a number. So we need the quantitative HCG. We need to know their blood type. And we'll go into more detail of why the blood type is really key with bleeding in first trimester. We'll also suggest getting a CBC, a complete blood count, so that we can see what their hemoglobin hematocrit baseline is, and also look at their white count to see if there's any potential signs of infection, and getting a sonogram, and understanding that if the pregnancy is too early, you might not see much on the sonogram. As she mentioned, the HCG level needs to be at least 1500 for us to at least see the sac, the gestational sac, which is the initial home for the fetus. If that number is too low, we won't even see a sac on a sonogram. So it's not even useful to even get the sonogram if that number is too low. But at least starting off with that basic blood work and the exam and your physical would be a great start. So what do you do when you have bleeding and you do see a potential fetus? Then we talk about potential miscarriages. You want to go into that?
I surely will. I do want to backtrack just a moment because I think you touched on something really important when you started talking about pregnancy hormone levels and what we call the discriminatory zone, which is the pregnancy hormone level value above which you will see something on an ultrasound. So I think it's important to not only for us as healthcare providers, but even also as educators for our patients to make sure they are aware and understand the importance of that value. Other things that are going to be important to sort of understand, especially when you're evaluating a patient for first trimester bleeding, is that on your ultrasound, usually you should see an embryo with cardiac activity, or what sometimes may be written down as FCA, or fetal cardiac activity. You also want to make sure that usually the embryo is about 5 millimeters in size or greater, to sort of be more assured about a viable pregnancy. And then if you happen to need to follow an HCG level for a patient, if that value is less than 5,000, then it really should increase by or double about every 48 hours, or increase by at least 50%, they will say, but usually double in a 48-hour period. So those are things that you kind of want to keep in the back of your mind, especially if you're evaluating a patient with first trimester bleeding, or, this turns into more than a one visit sort of evaluation for your patient. Right. And like Dr. mentioned, then we definitely need to sort of talk about, okay, if there's a fetus, in the uterus, what do we see? What does it mean? And potentially what happens next? So there are 3 to 4 types of what we call them in obstetrics abortions, but in the common community, we'll call them miscarriages. So the first one we want to talk about is what we call a threatened abortion or threatened miscarriage. In that particular situation, on your ultrasound, you usually have a wonderful viable fetus. You've got cardiac activity, and the measurements of the pregnancy usually match the patient's last menstrual period, or essentially are appropriate enough in size that, like I mentioned, you have an embryo, you have heartbeat, everything looks good. But in that particular case, the patient may present with bleeding, but the cervix is actually closed. So that's very reassuring. And in that case, everything else seems to appear okay. So we would call that a threatened miscarriage. And usually that patient will be closely followed until the bleeding resolves. And they continue care with their obstetric provider. The second potential option is if you see evidence of an intrauterine pregnancy, but maybe now the cervix is open and maybe there's no cardiac activity, but there's some evidence there that a pregnancy has been there or is still there, but now the cervix is open. So that may be an incomplete abortion, which essentially means that, or I'm sorry, not incomplete, an inevitable or incomplete abortion, which essentially means that the pregnancy is not a viable pregnancy. There may be products that have passed. So a patient may give a history of a gush of fluid from the vagina, or maybe even tissue passage from the vagina, but on your ultrasound, you still see that there are products of the pregnancy in the uterus, or what sometimes you may see written in your report as retained products of conception. Then you have your complete abortion. So that may be a patient who presents and gives a history of having had a positive pregnancy test. You may even have a positive pregnancy test in your clinical setting, but maybe they say, you know, they had a heavy bleed. Maybe they say they passed something that was like tissue. Usually they'll give a history of heavy bleeding, maybe passage of tissue, and then the bleeding actually probably gets significantly lighter. And then on your ultrasound, what you see is essentially a completely empty uterus or mostly empty uterus. So in that particular case, if all of the pieces fit, then you may say, oh, you know, I'm so sorry, but it sounds like you may have had a complete miscarriage or a complete abortion. So those are some of the main types. But then there's another one, sort of the obstetric emergency, the call your OB friend immediately, which is your septic abortion. So the septic abortion could present as any of the ones that were just mentioned above or before, but this patient now comes in and they actually look sick. So they may have fever, they may have chills, they essentially may look hemodynamically unstable, they may have heavy bleeding. And if you have had an opportunity to get some labs, you may notice that they have a white count, potentially with the left shift, and other signs or symptoms of an infection. In this particular case, please call your OB provider immediately, as they will need to assume care to make sure that this patient is managed appropriately. So with that, those are sort of your potential options for miscarriage types in your first trimester. Obviously, aside from the threatened abortion, none of them are going to be super happy times for the patient, but I do, you know, and all of us understand that being able to provide accurate clinical information to a patient is always going to be very reassuring, even in the setting of something that may not necessarily be the most desired outcome.
Yeah, that was awesome. That was awesome, Dr. Wilson. The other thing I wanted to add, just if you're seeing these patients, many of these patients with these potential miscarriages, you know, these are truly desired pregnancies, right? So just because they've had one miscarriage does not necessarily mean the next pregnancies are going to be miscarriages. So we always like to reassure patients when they're having a potential miscarriage that they have a high likelihood of having a normal viable pregnancy in the future. The only one thing that I just wanted to add with the complete abortions, with the complete miscarriages, what we normally do is if you have a patient come in, they say they have a positive pregnancy test, your test is positive in the office, but there's nothing in the uterus, and the cervix is closed, and we're assuming that they have passed everything. We still continue to follow those HCG quantitative levels until they are negative. And that
Yeah.
gives us reassurance that the patient has truly passed all the products. So just because you see an empty uterus, and you have their story, still follow those HCG quants down to negative, and we consider negative less than 5. And we usually have them come back in for blood work every 1 to 2 weeks, depending on how quickly that number is falling. If you have some concern with the follow-up, again, don't hesitate to give us a call. We are happy to do that follow-up for you.
No, but Dr. That's a great point to definitely drive home is please trend the HCG levels. I don't think any OBGYN you talk to would offer you any different advice. So definitely trend those levels.
Absolutely. So what happens when you have the patient who presents to your office space or to your urgent care or to your ER, and this happens to potentially be the second time they've come to see you, and the HCG levels are not trending appropriately, and you've done that ultrasound and you don't see anything in the uterus, but they're still having a little bleeding, not a lot, but still having some bleeding and some cramping and some pain. What are those kinds of things? What kinds of things are you thinking about? I know the number one thing I'm thinking about.
So, we are walking down the path here of things that are not the funnest things in the world.
Right.
My thought process is probably right there with yours, because I'm thinking ectopic pregnancy or pregnancy unknown location, because where it is not is in my uterus.
Right.
That's where it's not there.
Right, exactly. So if you have that patient who has HCG levels that are not trending upwards appropriately, ectopic pregnancies tend not to bleed as heavily as traditional miscarriages, so that don't expect them to be hemorrhaging, but they may have some significant pain. Sometimes it may not be significant. It may just kind of be achy anywhere in the abdomen. If that's the case, that's an urgent situation. So that's a referral to an emergency room for further evaluation, for ultrasound, for confirmation, consultation with the OBGYN, so that we can give some feedback and recommendations for treatment, whether that's medication or for surgery or what have you. But ectopic pregnancies can potentially be lethal, right? So we definitely want to make sure that you all are getting those patients into care quickly, and reinforcing with them how urgent that need is, that they're not just going to go home and wait a few days and then present to us. We need to get some answers as soon as possible.
Yeah, I completely agree. And even for some of those patients who may have started down the treatment path, especially if they are on the medication treatment path and they happen to present to your care site again, try and get as accurate a history as possible. And if anything seems amiss, please cannot implore you enough to call your OBGYN colleagues and get input right away, because sometimes medical management can fail and they may need intervention from us. And sometimes the patient will give you a story that seems a little bit off or out of kilter. So definitely consult us so that we can make sure that the patient gets the best and highest quality care that is available to them.
Absolutely. And that's even for ultrasounds that do show something in the uterus, but it looks abnormal, whether it's a molar pregnancy or something like that. If it just doesn't look right, if the radiologist is giving you some negative feedback with the findings and you're not quite sure, give us a call. So that we can begin to collaborate to keep these patients safe. So at the end of the day, we need our non-obstetric providers to help us manage these patients who are potentially bleeding in the first trimester, because they're not always getting into us very quickly. So hopefully this information that we provided will, get your kind of mind thinking about some of the things outside of your usual box. And for your patients who are RH negative, meaning if their blood type is negative, if they're having a significant bleed, they really should be getting an injection of Rogam. If you don't have that in your office, they can go to an emergency room to get that, or refer them to us so that we can administer that as well. If they're having a significant bleed in the first trimesters. The light spotting, we don't always give Rogam, but if they're having a pretty decent bleed in the first trimester or second or third and they're RH negative, then we definitely recommend Rogam. So
Mm.
go ahead.
No, I just said absolutely.
Yeah, absolutely.
It's important.
Yeah. So at the end of the day, we thank you all for listening to this episode of Birth Equity. Thank you for collaborating with us to break inequality and reimagine transformative healthcare. Please check out our other podcast episodes and look forward to the upcoming topics where we'll be doing a deep dive into some other obstetrical concerns where we would love to have the collaboration of our non-OB providers. Thank you.
Thank you for joining us.
Awesome. Take care. I'm Dr. Suleika Michel.
And I'm Dr. Tiffany Wilson.
And we'll see you next time.